speakers. Whilst this screen is on, I just wanted to invite everyone to the NCIC Annual Symposium, which has a theme of sort of tackling fungal infections using novel immune and diagnostic approaches. So we've got some great international and national speakers. As you can see here, Demetrios and Pedro from Spain, and we've got Julian speaking, and Shivani and Dave Gottlieb. We can put that up on the chat to please register. And otherwise, today we have an event looking at Clostridium difficile, and Pedro's got a recorded talk about his study that he did here when he was an overseas fellow. That's here, and then followed by a talk by Sam, which I'm looking forward to, and then Claire will also speak as well. So please feel free to put questions in the chat, and we'll take questions along the way. So thanks, Alice, for organising this. And
thank you for inviting me to present this project I started when I was there last year. And it's a shame that I cannot be there in person, and or at least online, but I will try to do my best to explain the results of this interesting project. So just a very brief introduction. As you all know, Clostridium difficile is the most common cause of healthcare associated infectious diarrhea. And especially cancer patients are very vulnerable to this infection, to CDI, because they commonly are in prolonged hospitalizations. They receive a lot of different and recurrent antibiotics, and also chemotherapy has been shown to alter the mucosa and somehow predisposed to Clostridium difficile infection. And overall, they said that the CDI recurrence is around 25 to 33% of patients following at least initial treatment with metronidazole or vancomycin, and this is even higher, getting to 45% in some series after a second recurrence. And this is just to show that, that this is the typical clinical manifestations. We all know this, but just to say that maybe one of the most important factors when developing Clostridium difficile infection is dysbiosis. We know that there are some species like these Firmicutes or Bacteroidetes that really are very important for the homeostasis of the gut microbiota, and when these species are not present, we can have like Clostridium difficile and other pathogens overgrowth, and then Clostridium difficile starts producing these toxins and causes this inflammatory diarrhea, and this can also somehow in these patients favor bloodstream infections due to enterobacterias mainly, but also candida and other pathogens. And at the end we can see the typical image of this pseudomembranous colitis. So in the last year there have been some new strategies to prevent recurrences, and for example fidaxomicin, which is known that it's much more selective for Clostridium difficile, and this causes less dysbiosis, and by this it reduces clearly the risk of CDI recurrence. We could also use belotuximab, which is a human antibody that neutralizes Clostridium difficile toxin B, which it doesn't eradicate Clostridioides, but inhibits the production of the activity of this toxin, so inhibits the diarrhea, and it has a quite prolonged half-life of approximately 19-20 days. So the effect can be long, and could be a good thing to do in these patients that we know that keep on being at risk of recurrences. And finally, in the last years, it has been clearly shown that FMT, fecal microbiota transplantation, is very effective in preventing CDI recurrence, probably because of it restores the gut microbiota composition, and as we said before, this is a very important factor in the CDI recurrence. But the point is that there are no specific evidence or recommendations in cancer patients. These patients have been commonly excluded of these trials with these new drugs. So it's very difficult to know what to do with this specific population. And just I'm very short with the methods of the study. This is an international multi-center retrospective cohort study. There's 3 different centers in Australia and 1 center in Spain, Peter McCallum, Royal Melbourne, Austin Health, and then Hospital Clinic here in Barcelona. And we collected all episodes of CDI in adult patients with either hematological or solid tumor malignancies between 2020 and the end of 2022. And we basically assess mortality and related mortality at 90 days, and recurrence was evaluated both at 90 days also and at the last follow-up of the patient. And if we go with the results, so we collected a huge number of episodes, 547 episodes of CDI among cancer patients, which is quite extraordinary. And we can see here the characteristics of the cohort. 49% were females, median age was 66 years, so quite young for Clostridium difficile cohort. And patients didn't have a lot of comorbidities, but still the Charlson was relatively high, 5, because of the cancer itself. And then we can see here that more or less half and half of the patients were solid tumor and hematological cancers, and the most common cancer was lymphoma, followed by acute myeloid leukemia. And also, if we look at the solid tumor cancers, that maybe colorectal, breast cancer, lung cancer, and squamous cell carcinoma. It is important to disclose here that we don't have the denominator of patients, so we don't know how many patients were at risk of developing CDI in this population, so we cannot say that incidence is higher in acute myeloid leukemia or in colorectal cancer. This is just the total number of patients with CDI. And if we go to the treatments and other risk factors, a lot of patients, almost 3/4, receive proton pump inhibitors as a part of their usual treatment. Rates of pre-remission were really high, as expected in this kind of populations that keep being admitted at the hospital. Over half of them were actually admitted when the CDI was diagnosed, and also rates of prior surgery or other invasive procedures like endoscopies or these kind of things were also quite high. In the last month, 50% of the patients had received chemotherapy, low rates of radiotherapy, and also high rates of other immunosuppressive therapies or corticosteroids. And this is an interesting thing. We checked how many patients had a rectal swab for multi-drug resistant detection in the last months, and almost 50% of them had a rectal swab performed, and of those, 36% had a positive result, so had a positive multi-drug resistant isolation. So regarding prior antibiotic, over 2/3 of patients had received antibiotics within the last 30 days, and almost half of them were on antibiotics at diarrheal onset. Median time of antibiotic therapy was quite high, or like 10 days of treatment more or less. And if we check which antibiotics were the patient receiving, so again we can see here the most common was piperacillin tazobactam, then carbapenems, and then third generation cephalosporins, and finally amoxicillin clavulanate. But again, this is not something like you can say these antibiotics produce more Clostridium difficile. This is probably just a reflection of the antibiotics we're using commonly in this population. So regarding clinical presentation, most of the patients had moderate diarrhea at presentation between 4 and 8 stools per day. And almost half patients had fever, and 21% of them had high fever at presentation, 38% abdominal pain, and 50% vomiting. And if we look at very severe cases, only 10% presented with hypotension, only 2% septic shock, and then only 7% require ICU admission. So not a lot of these very severe cases. Blood tests. This is mean leukocytes, CRP, albumin, and just say that around 11% had leukocytosis, over 15,000 leukocytes, which is not much, but also we have to consider that 30% of patients had also neutropenia, so it's not that bad. Many patients had actually leukocytosis, and then CRP was high in almost half of patients, over 5. I put the cutoff, which is relatively high. And then 50% had hypolbuminemia, and as I said, 30% neutropenia, and 12% had acute renal failure on presentation. And interestingly, also CT abdomen was performed in a quarter of patients, more or less, and it was pathological in 18% of the patients. So this is a figure with the severity of the episodes regarding SMIT or IDSA classification, and we can see one of these severe complicated cases, as I said before, those with hypotension, septic shock, or toxic megacolon, both in both classifications would be around 11% episodes, and there's some difference between non-severe and severe episodes, 50 to 70 and 20 to 39%. That's mainly because SMIT classification classifies patients as severe episodes when they have like over 50,000 leukocytes. That's the same in IDSA. And then we can see that acute renal failure, which is creatinine over 1.5 in IDSA, and then SMIT includes this high temperature as a severity factor, and then also this CT abdomen abnormalities as a factor. But overall, similar classification. Around half, a bit more of episodes are mild, and then severe cases around 20 to 40% more or less, and only around 10-11% of cases are severe complicated cases. So regarding cessation of prior antibiotics, this is interesting. Only 21% of patients stop the prior antibiotic, and 32% of patients continue antibiotics, and the other patients were not receiving antibiotic mainly at that time, so it didn't apply. And if we see which antibiotics were used, so you can see that clearly in our cohort, vancomycin was the predominant use antibiotic, 82% both in Spain and Australia, and followed by metronidazole, commonly as a combination therapy, third place for fidaxomicin, and then finally a few patients receiving tigecycline, mainly as a combination also. And as I said, 11% of patients had received antibiotic combinations, mainly with tige or metronidazole. Yeah, and we can see here also that 18% of patients need to change the treatment at some point, mainly because the patient was not improving properly. Regarding outcomes, as I said, very few severe or severe complicated cases. 6 patients require surgery, 35 patients require parenteral nutrition. Then 10% of patients had bacteremia, and 30 days following CDI, which is quite interesting. And then high morbidity with 25% of patients requiring parenteral admission within 30 days of discharge. Interestingly, as I said before, 90-day mortality was high, 22%, but attributable mortality was very low, less than 5%. And 90-day recurrence was 15.6%, somehow lower than other series. And if we follow to 1 year, the recurrence rate increased to 19.4%. And interestingly, most patients receive systemic antibiotics between the initial episode and the recurrence, which is expectable in this kind of population. And although the recurrence rates were relatively high, prophylactic strategies were very uncommonly used, only 24%, and this was mainly vancomycin heparin, which was used, but very low numbers of velotuximab or FMT or other strategies. And as I said at the beginning, the risk is theoretically increased with new episodes, so we wanted to check this, and we can see after the first, second, third, or fourth episode of CDI, which is the risk of a new recurrence, and we can see here there's a trend to increase recurrence risk with new episodes, although there's a gap here, and I think maybe the numbers here are not so big, so it's very difficult to extract conclusions from this figure. And now regarding risk factors for CDI recurrence, which was the main outcome of this study. So this is the results for the multivariate analysis, and we can see here that females had higher recurrence, which is quite interesting. Maybe you can talk about that later. We're not sure about what's the reason for that. Maybe something related to microbiome in female patients. Very elderly patients, which is a classical risk factor for recurrence. Dialysis, probably because of a lot of healthcare relatedness in these patients. Colonic wall thickening and CT abdomen, I think this is a marker of severity. And then, interestingly, vancomycin therapy. I think we need to stop a second here. Vancomycin therapy was an independent risk factor for recurrence, but still I think one of the main limitations of this study, when we analyze the results, is that a lot of patients receive many different antibiotics, and then I don't know, for example, 3 days vancomycin and then 10 days fidaxomicin, or 2 days fidaxomicin and then vancomycin, and it's always difficult to assess which is the weight of any of these antibiotics when you are assessing an outcome that's happening, I don't know, 30-40 days later. So very complicated, but we decided to include as a treatment every drug that the patient had received over 5 days. And with this classification, vancomycin was clearly associated to increased risk of recurrence in the long term. Although it's also difficult to assess because, as I said before, most of the patients had received vancomycin in the cohort. So it's clear that we need even bigger studies to keep looking on that. And then Enterococcus bacteremia, which is interesting. Probably this is a high risk factor, but this is probably related to dysbiosis. We know that Enterococcus tends to predominate when there is a lot of dysbiosis, so it's probably a marker of the microbiota composition. And then we're not sure about but vomiting presentation was protective. Maybe these patients in which upper symptoms predominate had less severe episodes, and then they have less risk of recurrence, but this is only an hypothesis. And we can see here the ROC curve for recurrence prediction. We can see the curve is relatively nice, but if we check at the area under the curve, we can see it's only 0.728, so not so great, actually moderate capacity to predict 90-day recurrence. And this is a Kaplan-Meier for vancomycin and other treatments. Other treatments, mainly fidaxomicin, and some patients with metronidazole also tricky there, because we saw also that patients receiving metronidazole had clearly less severe episodes, so maybe they recur less, but because they were less severe. But as I said before, if we look only at the numbers, clearly increased risk of recurrence quite since the beginning, and especially after 60 days. Here the line tends to make a plateau, and on the other hand, the risk in these patients continue to increase further in time. So attending to these results, mainly we had to think again about vancomycin in the setting, at least in high-risk patients. And this is something we wanted to look also, the cycle threshold value and its relation with recurrence. You know, cycle threshold means more or less when the cycle threshold, the CT is lower, it means that there are a bigger load of C. diff. So with this in mind, some prior research has related low CTs with higher severity, and we wanted to check that also in these patients, and we can see that in the univariate analysis that was a clear relation, and it lost signification in the multivariate analysis, but the p is 0.06 or something like that, so almost significant. And here we separated these three different groups regarding the CT, and we can see clearly that the patients with lower CT had earlier and higher rates of recurrence than patients with other CTs. So I think this is also an interesting thing to look at in the future. And this is the multivariate analysis for mortality. As I said before, the overall mortality was high, but attributable mortality was quite low. So we decided to look only at risk factors for attributable mortality, because the other mortality was mainly related to cancer. And we can see that previous cerebrovascular disease, age, need for treatment change would make sense because patient wasn't improving. High output diarrhea, altered consciousness, elevated CRP levels, all were increased the risk for mortality, and antibiotic therapy within the prior 30 days decreased the risk for attributable mortality. I think these are all markers of severity of the episode mainly, or very frail patient before the episode. This is because it wasn't improving, and I think this maybe means basically that patients receiving antibiotic in the prior 30 days, so you are more aware of patient likely having C. diff, so you start treatment before, and maybe you control the disease earlier, but this is only a hypothesis. And we can see here the curve in this case is quite nice, AUC 0.9, so excellent capacity to predict attributable mortality. So, and now if we go to the discussion very briefly. So I think it's better that you discuss these results together, but I will give just some headlines. So I think it's clear that we have a huge cohort of patients, mainly young cancer patients, with low prevalence of comorbidities but high rates of health exposure, chemotherapy, surgery, and other medical procedures. Most patients have received antibiotic in the previous 30 days, which is expected. Among patients who underwent rectal swab, as I said before, high proportion of them were colonized by MDR bacteria, which is also some research about this and relating prevalence of MDR bacteria and loss of diversity of the microbiome, which is, as I said before, related to CDI. And a significant proportion of patients were classified as having severe or severe complicated CDI. This is also interesting. I didn't say before that, you know, there's also many of these factors that related with severity in cancer patients, like chemotherapy or some other factors, are not included as as a severity factor, and also many of these patients were neutropenic, so they were not able to have leukocytosis, for example, as an item for severity. So still, severity was relatively high in the population. And then, although 90-day mortality was high, over 20%, 30 CDI-related mortality was low, below 5%. But however, the morbidity was significant with prolonged hospital stays, high readmissions, and high incidence of bloodstream infections following CDI. Vancomycin was the most used antibiotic, nearly 85% of cases. Metronidazole about 20%, often in combination, and fidaxomicin was relatively rarely used. And 90-day recurrence were high, 50% among accessible patients. That I didn't say before, but we assessed recurrence only on those patients who were alive at 21 days. And then vancomycin seemed to be increased with seem to be associated with increased risk of recurrence. And I think identifying high-risk patients is essential, because probably some of these high-risk patients would benefit from other strategies. I don't know, maybe fidaxomicin or even FMT or obinutuzumab, but probably considering that the low severity and that the risk of recurrence wasn't so high in this population, it's not also easy to say we are going to use fidaxomicin for everyone, because the costs are clearly much higher with fidaxomicin, and this is also an important issue. So, and this is only one thing that we are working on now, because I think maybe in the future we can work together in that. We have now this project. We are collecting stool samples in CDI patients, day 0, 10, and then 30, and then in these stool samples we are analyzing the microbiome, and with the lab people we are developing this thing here, this short chain fatty acids analysis. This is because some of these species of the microbiota produce these short chain fatty acids, and then you can measure this in the stool directly, and then it could be like a marker of how healthy your microbiome is. And maybe if we identify that less healthy microbiome is associated with higher risk of recurrence, we could do some different strategies also in these patients that we certify this loss of diversity, so like FMT or probiotics or things like that. And then the limitations, I think I already talked about this, but we don't have the denominator of patients at risk, and we lack a group of control, so we cannot determine the incidence or impact of various factors on CDI development. We didn't have C. difficile sequencing, so we couldn't really differentiate between recurrence and reinfection, and we didn't have information about hypervirulent strains, although I think in our setting not so common. And also this is a retrospective observational study, so some episodes and recurrences may have been missed, and as I said, also we didn't have a standardized therapeutic and prophylactic interventions, so it was a mix of different strategies, different lengths, and very difficult to interpret. And yeah, this is I think the main limitation. Okay, and so thank you for listening. I hope you like it, and I wanted to take advantage of this opportunity to thank everyone who helped me with this project, especially Rachel, Megan, Krishna, and all the doctors, and it was a big pleasure for me and for all my family to be there in Melbourne. It was an incredible experience, and I hope to see you soon in the future. Thank you, bye-bye.
Okay, thanks Pedro for recording that. That was super, super interesting. A bit hard to ask questions when he's not here, but suffice to say that was a lot of work, one of the large studies of C. diff in cancer groups internationally, and some really interesting, sometimes somewhat unexpected findings. So I think he's about to publish that. Please pop any comments in the chat and I'll pass that on if you wanted. So now we'll just move on to Sam Costello. Sam, thank you very much for joining us. If you wouldn't mind sharing your slides, and do you mind just a little brief introduction of where you sit and your different various roles? That would be great.
Yeah, thanks, Michelle. Thanks very much for the opportunity to present. Yeah, so I'm a gastroenterologist based in Adelaide. I'm at the Queen Elizabeth Hospital, University of Adelaide, and also at Biome. And that is Biome is a company established with the Hospital Research Foundation, and it is a conflict of interest, as I, as well as the other co-founders, have shares in that company. So that needs to be taken as a conflict here. So just a bit of background on how we came to set up Biome and supply FMT in Australia. I undertook a PhD focused on fecal transplant for ulcerative colitis, started in 2012, and during that time set up a stool bank in an academic laboratory here in Adelaide to supply the trial, but then at about that time, a paper came out in NEJM showing FMT efficacy for C. difficile, and so we started to supply patients with FMT to treat C. diff. And then towards the end of the study, we had a positive outcome in that study for induction of remission in ulcerative colitis, but also an established service for C. difficile. So we started to treat about 30 patients a year locally, but we had no further funding. We had an HMRC grant for the trial, but that run out. And so we had to sustain the service and couldn't do so through the local health network, and eventually had some funding from the Hospital Research Foundation, but they actually set that funding mechanism up through establishing a company so we could transact with hospitals, essentially so that it could be a sustainable service. So the payments for the FMT would be would cover the costs, and also so that we could meet the requirements for the TGA, because we'd been the TGO 105, that regulatory framework had been being sort of established around that time. The other thing that we did was towards the end of that study, I collaborated with a group in Cambridge, and Sam Forster, an Australian microbiome scientist based now at the Hudson, discovered methods to culture previously unculturable human gut microbes, and published a paper in Nature outlining that. And so we set up a collaboration to try and use FMT data and the FMT stool to grow out the individual microbes with the ultimate aim of producing cultured microbiome therapies. And so that's our longer term aim. But the most immediate pressing need was for C. difficile infection, and supplying FMT. As you know, FMT can be, C. diff is a refractory or recurrent C. diff is a big problem in Australian hospitals, and in cases where antibiotic therapy is failing, FMT can be highly effective. And this was really demonstrated well for the first time in this seminal paper published in NEJM in 2013 from a Dutch group that showed FMT delivered via nasogastric tube could give remission rates between 80 and 90% versus the then standard of care vancomycin for recurrent C. difficile infection. And this study was actually ceased early by the ethics board, given the very large delta between those two groups. It was felt unethical to proceed with the vancomycin arm. And that similar studies, other RCTs have been conducted now around the world using different methodologies of delivery of FMT, so colonoscopy, enema, capsule. And on meta-analyses of these studies, you can see that both for a single FMT versus vancomycin, but also for repeat FMT versus vancomycin, there's superiority of donor FMT over vancomycin treatment, and the level of evidence with meta-analysis of multiple randomized controlled trials is high for multiple FMT treatments and moderate according to the grade level of evidence. And so really now FMT is in national and international guidelines for the treatment of C. difficile. The most recent guidelines published internationally, the American College of Gastroenterology guidelines, where FMT is recommended for patients experiencing the second or further recurrence of C. difficile. They also recommend, given the weight of evidence in RCTs, for colonoscopic delivery or capsule, with less evidence for enema delivery, and then suggest repeat FMT in patients who recur in the 8 weeks following an FMT. So although that level of evidence is low, and so FMT is in Australia regulated as a biological, so either a class 1 or 2 biological, and this is established through the TGA 105 framework. So the TGA were in a difficult position, like regulators around the world, where FMT was being performed in hospitals and in the community without any regulation. And so they brought together key stakeholders, infectious diseases physicians, gastroenterologists, patient groups, and others, and formulated this framework whereby a class 1 biologic would be considered for a doctor compounding an FMT in the institution. So Peter Mac, if you were to compound FMT product, you could deliver that to your own patient at the same institution, but not deliver that to another institution. A class 2 biologic needs to be manufactured, however, in a clean room with GMP systems in place, and that could be distributed to other parts of Australia, and that could be listed on the Australian Register of Therapeutic Goods once that dossier is approved. So that's the process we went through at Biome, and we achieved that in November 2022 when Biomicture was approved and registered on the ARTG, and that was the first microbiome therapy approved worldwide. But there are now 2 other therapies. So the FDA approved Ferring's product, which is an enema delivery FMT product, and Seres Therapeutics developed an oral capsule, which is an ethanol washed FMT product, again for C. difficile infections. So there are now 3 approved FMT products internationally, which really has opened the pathway for regulatory approval for other microbiome therapies, which is really a fantastic development for the field. And so looking at patient selection, who should receive, where there is evidence, and the guidelines would recommend patients receive an FMT. So the most guidelines state after 2 recurrences of C. diff, and this is predominantly because the rates of so having diminishing returns from subsequent antimicrobial therapy after each failed treatment. The data we saw just earlier show actually lower rates of recurrence than this, but these data were from earlier results in the literature. So potentially with newer antibiotic therapies, this may be lower, but in any case, second recurrence is for the approved therapies, and in other guidelines is generally the recommendation. And then another factor that comes into the consideration is the severity of the episode, and this is principally because severe FMT resulting in hospitalization or shock portends worse outcomes, so higher rates of recurrence, but also rates of colectomy and death. And so in this population, there are not randomized control trials, obviously a difficult population to do that, but there are case control studies. So 2 studies, both one from New York and the other from a French group, and they had very similar results showing that with severe antibiotic refractory CDI, the mortality rate is high, so can be up to 50%, and despite patients having colectomy, and the number needed to treat in that population in these case control studies to prevent 1 death using FMT was only 3. So So potentially patients can benefit from FMT in that setting. And in our local data in South Australia, we found that patients defined as having severe C. diff have higher rates of failure of FMT. So most of the patients, or all of the patients who have failed fecal transplant and progressed to either colectomy or have succumbed to the infection, had severe CDI. And the other third indication really is patients not responding to antibiotic therapy, where their only alternative treatment is colectomy. So FMT has increasing safety data. So the largest study looking at this was a systematic review published in 2021 that included over 5,000 FMT cases over a 20-year period. And they found that about 19% of patients who received FMT, mainly for C. difficile, but a number of other indications in clinical trials, had developed an adverse event. The vast majority of these adverse events were mild and self-limiting, so diarrhea, abdominal discomfort, nausea, vomiting, flatulence, typically GI symptoms, hard to disentangle from the underlying diseases being treated, and self-limited. About 1.9% of patients experienced a serious adverse event, and this was higher for patients receiving FMT via the upper GI delivery route. And there was mortality rate of 0.13%. So 5 patients died in this analysis. 4 out of those 5 had aspiration events from upper GI delivery of liquid FMT, and 1 from the transmission of a multi-drug resistant ESBL E. coli. And so the colonoscopy had actually the lowest rate of both adverse events and serious adverse events of these delivery methods. So in South Australia, our service has been running since 2012, and we've treated close to 200 patients now, with an overall cure rate of 96%. So that includes patients who have had a primary cure rate, in this case, approximately 90%, and those failing treatment with the first FMT having a follow-up FMT. So we've had 5 patients undergo colectomy and a single death from CDI sepsis. And in that period of time, we've also treated 160 patients in the clinical trial setting for Crohn's disease and ulcerative colitis predominantly. So Biome FMT is the approved product in Australia. It's now supplied to over 70 hospital networks around the country. We use an anaerobic manufacturing method, so manufactured in an anaerobic chamber to avoid oxygen exposure, and it's delivered in a syringe, typically into the bowel directly at colonoscopy. And the aim there is to really preserve the viability of the microbes in the preparation, and we're reformulating this into a capsule. So this capsule is now being supplied to clinical trials, but is not yet approved and needs to go through that process with the TGA. These are some data from Lido Papanicolaou, an ID physician microbiologist in Adelaide, who looked at anaerobic processing of FMT, and you can see that many of the obligate anaerobes, when processed under air, are non-viable following that. So we see that this is not necessary for the treatment of C. difficile. Aerobically processed stool is still effective for that indication. But if we want to use FMT for drug discovery to identify organisms associated with benefit, then we want to preserve the maximum viability of the composition, and that is why we've taken this approach. And we know that FMT is highly effective for C. difficile infection, but there are limitations to FMT. It is difficult, it is variable in its composition because each donor is different and each stool is different. So it's really difficult to define the mechanism of action, and we're unable to engineer or change the product's composition to enhance efficacy or improve safety beyond donor screening. And so cultured therapies certainly have an advantage in that space. We can control the composition and potentially enhance efficacy and safety through including organisms associated with efficacy or excluding pathogens. And we can, if we can culture these in a bioreactor, we can scale the therapy to larger populations and not be restricted to donors. So that is one of the aims of what we're doing. We do supply Biomicra for the treatment of C. difficile, but also supply clinical trials in these other indications with the aim of developing cultured therapies with our collaborators at different hospital networks in Australia. And so this is the approach we take. We use, just to give an idea of potentially where the future's going with these microbiome therapies, we use FMT in these populations, and we can interrogate both the clinical metadata with microbiome data to identify strains or mechanism of action associated with a clinical response, and then go to our culture collection. So we have over 30,000 isolates now using Sam Forster's culturing methodology. And we can select those strains and take them through as cultured therapies, grow those in a bioreactor and then freeze dry and encapsulate with the aim of producing a cultured version of the original product. And this is how we can assess those data. So we can look at patients at baseline, and they may have organisms that then disappear following or regress in the background following an FMT. They would be targets, potential disease-causing organisms, and organisms present in the donor but that are not present in the recipient may be leads, and these might be considered as microbiome therapies in their own right. And so the other key thing we've developed with Sam and the other scientists we're collaborating with is the ability to grow these microbes, a diverse mix of microbes together in the same bioreactor. So we've been able to grow over 100 microbes, and so that covers off about 90% of the gene families you'd find in a healthy human microbiome, and so a lot of the function. The idea then is that this could look a lot like the original donor FMT, but be able to be controlled in its composition. We've constructed a therapy for ulcerative colitis, not for C. diff, but this approach could potentially be undertaken for other diseases. And you can see the phylogenetic tree here of this therapy looks much like a healthy human donor in its diversity. And each strain, though, has been selected based on, in this case, its ability to consume hydrogen sulfide as a mechanism of action. And also these strains being associated with clinical benefit following FMT in the FMT studies we ran in ulcerative colitis. And having the ability to control the composition, we can put these mixes into a bioreactor in the stool of patients with disease, and really interrogate what's happening here. And we have had one interesting discovery that we believe may explain why FMT is efficacious and single strain therapies have typically not been. And that is because we find that with a diverse mix, we get emergent therapeutic phenomena occurring. So in this case, our mix of strains that can consume hydrogen sulfide, we compared that to the single strain in our collection that most potently consumes hydrogen sulfide as an individual. But when applied into the stool of a patient with ulcerative colitis, we found that the consortia, the diverse mix of strains, outperformed the individual isolate. And so this is an ecological phenomena that's very common in ecology. We can see the benefits of diversity and the synergistic effect that diverse composition brings. And we believe that may be an explanation as to why FMT is actually effective, but many existing probiotics haven't been. There are also challenges in growing such a consortia, and so we've been working with bioreactors at small scale, up to 20 litres, looking and been able to reproduce this mix, but it's still a way away from the clinic. We're aiming to enter a clinical trial next year. So in conclusion, FMT is the current standard of care for recurrent and refractory C. difficile indications, so for 2 or more recurrences, and is approved by the TGA. It appears in case control studies to be an effective therapy in the setting of severe CDI with a number needed to treat of 3 to prevent 1 death. And FMT may be valuable to inform the discovery and development of microbiome therapies, cultured versions. And we've found that our consortium platform, the ability to co-culture these organisms, can produce a diverse cultured version of the FMT product that we hope will enter clinical trials next year. And through that process have demonstrated that emergent therapeutic properties of diversity of the microbiome more than individual strains alone. So this is our team. We have collaborators throughout Australia and the local hospitals and universities also. Thanks.
Thanks, Sam. That was fascinating. Very, very interesting. I just open up to any quick questions that you may have for Sam, bearing in mind that we still have Claire, who's just going to present a few different slides of her Monash experience. Hey, Gab.
Thanks, Sam. That was fascinating. I work in both pediatric and adult ID. I was wondering if you could share any thoughts about where you think this technology might be useful in, like the stem cell transplant population, for instance, to reduce some of the gut-related complications, or are we a long way away from something like that?
Yeah, that's a great question. I mean, I'm sure you probably know the data in oncology and in that population better than I do, but I do know that broadly poor outcomes have been associated with a reduced diversity of microbiome going into many of these oncological indications. And in fact, there are some data, particularly with checkpoint inhibitors, that potentially FMT therapy can be effective. But we are starting we're going to start a study supplying FMT in the context of hematopoietic stem cell therapy population who are having mucositis, and so with Hannah Wardle through SAMRI. But we
I met her at Mask, actually.
Sorry?
I met her at Mask.
Oh, right.
Recently. Yeah.
So we don't have any data yet, but that would be it is potentially really an interesting population to look at.
Okay, thank you.
And just sort of briefly, you've got a lot of experience with the FMT that you're delivering over in South Australia. Would most of that be delivered by colonoscopy, and does that include the severe ICU hypotensive cases?
Yeah, so yes, so most of the delivery has been colonoscopy. However, that is a group where we've often used either enema initially, or if they've had a nasogastric tube placed, or push enteroscopy. So we've performed FMT in a few cases of toxic megacolon where surgery has been declined or not possible, and in those cases we've used push enteroscopy usually, so like essentially a pediatric colonoscope into the upper gut, or if there's an existing tube in place, that because we've not wanted to go into the colon, and those cases have largely been successful, but there's not a lot of evidence in that setting, and so it's just been like an intuition not to go into the colon in that setting.
Wonderful. Thank you. Hold off any further questions, and we'll just get Claire Dendle to speak, if that's all right, Claire.
Sure. I'll just share screen. Okay, I've just got a couple of slides. So my brief today was to just talk about how we actually set it up this year at Monash Health. So we didn't have FMT until January this year. Our first case was the indications that the first two speakers have talked about. So basically it was recurrent C. diff. And I've put this here as a slide because actually you have to make really sure that they have recurrent C. diff. So we had a couple of false starts where, you know, the testing is actually tricky. So the first thing, I guess, is to make sure that they have got diarrhea and or pseudomembranous colitis, and they have definitely got a positive test, and they have failed 2 lines of therapy, 1 vanc and 1 fidaxomicin. Our patient was 82, had some comorbidities, not immunocompromised, but it had 9 relapses of C. diff in a year, and basically 1 relapse was sort of merging into the next. So she essentially was having lots of hospitalizations and really decreasing efficacy with each antimicrobial course. So the decision was made to do FMT, which we hadn't done at our institution before. So what I'm going to outline for you is really, I have 2 slides just with the steps. Sounds easy, was not easy to set this up. So I hope there's some learnings for your unit. I think you are planning on setting it up at some point. So I suppose the very first thing is the cost of it in this fiscal environment. So the approval process, because really the majority of the work into getting it is getting it funded and then getting the documentation and the processes in place. So the way we did it at Monash Health is a business case was presented to the Therapeutics Committee, really taking into account the costs that the patients would incur from repeat admissions, medication costs, etc. And our Therapeutics Committee allocated some funding so that we could perform a limited number each year at Monash Health. The cost of the whole thing seems to be somewhere between $5,000 and $10,000. I think with inflation, it's more like $10,000 now. So the product, I think, and I could be corrected here, is somewhere between $4,000 and $7,000. And that's including transport, all the other factors around that. And then there's colonoscopy and other costs. So it's certainly not a cheap option. So from a clinical point of view, once that was kind of approved for the hospital, we worked on getting a procedure of how it would work. So the clinical team determines that it's definitely C. diff, it's definitely recurrent, excludes other causes of diarrhea, importantly infectious and non-infectious causes. And I won't go into that now, but that's a really key element. Determining if there's any contraindications, and I guess some important ones to consider are, is the patient actually requiring antibiotics? Because if the patient is requiring antibiotics for other kind of things, then this is a very difficult thing to undertake. So in the patients at Peter Mac and the allo patients, I think that's an important consideration. The next step is then the head of gastroenterology and infectious diseases need to review the patient and the patient plan and approve it and just sort of sign off on the cost. Next, the gastroenterology team sees the patient. They get consent from the patient. At Monash, we've been delivering them all via colonoscopy. They organise the endoscope and book it with a time on the afternoon list due to having to thaw out the product. And then they inform the ID team of the date and time. The ID team then take over. They liaise with the Adelaide Biome Bank. The time it takes from like ordering the FMT to getting it into the patient is about 10 days. So you need about 10 days. So it's like planning takes a while, probably 5 days of that is paperwork. But it does have to be flown from Adelaide in a -70, like -70, and then thawed out. It's got to have a cold chain. The patient is put on vancomycin until 36 hours before the FMT, at which time it's ceased. The time is locked in, the patient undergoes bowel prep, the gastro team then thaw out the product, suction as much residual stool as possible from the patient, in full PPE, instill the product, and then they're discharged the same day. So in our institution, gastroenterology follows the patient up pretty much at 2 weeks and then 8 weeks. Most of the data shows that you should have a response by 8 weeks. And if there's ongoing diarrhea or symptoms at 8 weeks, we retest. And as Sam said, consider whether you need a second one. So we've done 3 patients. The first patient is really unfortunate. She actually got C. diff in the first place from being treated for recurrent ESBL E. coli UTIs. And she was also on a proton pump inhibitor. So she got her FMT and it was great. Her symptoms went away. She was just fantastic. And then she got a UTI and got meropenem and has had a relapse. So that's extremely unfortunate. The second patient is good, is clear. The third patient, I believe, was a transplant patient. I haven't been around Monash, but I have been told last night that the patient has actually relapsed. So that's our experience so far. So this is, I don't know if this is of any interest to you, but this is like the form the ID reg has to fill out. It's pretty basic. It's sent through to ID. So essentially ID does the ordering. So funding is the probably key barrier. We are starting, sorry, I spelled trials wrong. We are doing a starting clinical trial at Monash, and I think RMH is doing it as well, which is the VE303 trial, which is a trial of a bacterial consortium, which is 8 non-pathogenic Clostridia products that are cultured in the lab rather than fecal products. So that is actually commencing, I think, next month. And just finally, I suppose, a comment on, there's this perceived barrier that immunocompromised patients can't have this therapy, but I think there's more and more evidence that it's probably fine in immunocompromised patients, as long as depending on the gut integrity of the gut mucosa. So that's basically our experience.
Thanks so much, Claire, for sharing that. That's really wonderful and gives us sort of food for thought of how long it takes to set up. But once the system is there, I'm sure it just gets a little bit more smooth each time. But thank you, everyone. I don't know, Sam, if you had any final comments.
No, that was good. Thanks, Claire.
No, thank you for the FMT.
Yeah, no, thank you. You probably think, oh, Melburnians are still a bit behind.
No, it is a hard thing with it essentially not being funded, and so we're ultimately hoping that that there'll be a capsule product available and that ultimately be on the PBS, either ours or another company's product, because that's going to just make the system so much easier, because we're not having to deal with that on a patient by patient basis. That would be the best outcome.
So thank you, everyone. I think we've gone a little bit past the hour. I just want to thank our speakers all today, and thanks very much. A lot of discussion. See you.